Welcome to the NEI podcast. In this episode, we present a series of extended Q&A sessions recorded at the 2024 NEI Congress in Colorado Springs, Colorado. Faculty members who presented at the Congress will respond to unanswered questions from selected presentations. Stay tuned for insightful discussions.
Hello, my name is Dr. Katherine Dahlsgaard, and I will be answering your questions about my joint presentation with Dr. Jeffrey Strawn, Panic on the Playground, Managing Social Anxiety in Pediatric Patients. So let's get started. One of the questions was, what about social anxiety causing selective mutism? Do you prescribe CBT or medication? Selective mutism, which is a kind of an early childhood pernicious form of social anxiety disorder, but should, I think, be understood as an early and pernicious form, really, of a behaviorally inhibited temperament. So Jerome Kagan identified the fearfulness temperament, I believe in 1958, and then renamed it the behaviorally inhibited temperament. But these are children who, from early infancy, show remarkable reactivity to unfamiliar situations and unfamiliar people. When I treat selectively mute kids, and these are children who speak normally and joyfully at home, they're chatterboxes, they love to dance, they love to sing, but in preschool, kindergarten, first, second grade, they fail to speak in social situations where speech is expected. This is a particular love of mine, a particular wonderful subspecialty. I think I've treated hundreds of these kids from start to finish. And these children respond beautifully to CBT, particularly exposure-heavy CBT. What is the exposure to for children who fail to speak in situations where speech is expected? Of course, it is speaking, and it is speaking despite their anxiety. So behavioral therapy, in this case, is wonderful. We start with having them blow at me and then make phonemic sounds, particularly the voiceless sounds. And then we move on to the phonemes that involve a larynx, like and And for those of you who are listening, take your first and second finger and put them over your larynx, and then make the sh and p and k sound. Your larynx won't vibrate, but if you go or ah, you will hear your larynx vibrate. So that's what I mean by voiceless sounds. And the voiceless sounds, the sh and p and k, are easier for selectively mute kids to make. So we move from those to the phonemes where their larynx does rattle a little and it feels like real talking, and then I get them to answer single word questions with one word answers. And then we move up the hierarchy to full sentence answers, great full sentence, to asking structured questions. I have them take a poll and walk around the waiting room and ask everyone waiting in the waiting room, what's your favorite color? And then mark it down. And I give them rewards for every single person that they ask. And then I also have meetings with teachers and train the teachers to do these things in the classroom. Because, of course, the biggest goal for treating selective mutism in kids is indeed getting them to talk at school, right? That's their job. That's where they work. That's where they see their friends. So they respond beautifully. We do have two randomized controlled trials of medication. I think the first one was in 1995. And these children do respond beautifully to SSRIs. I will typically call or recommend an SSRI if I can work with the child and she'll get to answering, she'll answer anyone, but I cannot get her to initiate speech. That is to be the first person who talks, either what's known as an instrumental initiation, meaning I ask a question or I ask for help. Can you help me with my backpack? Can you unzip my jacket? Or even more importantly, social initiations where they will go up and say, teacher, we went to Dutch Wonderland this weekend, or go up to a friend and say, oh, we went to Dutch Wonderland and my favorite ride was the swings. So if I get a kid who will not initiate, I will recommend medication because they do respond. It's well tolerated in these small children. And that often, I think even better than what I can do via exposure-based CBT, gets that effect, the initiation effect. So I'm a big fan of medication for selective mutism. Parents worry about these medications for very small children. But in fact, we know that medications like fluoxetine and sertraline for children even as young as 4, 5, 6 are well tolerated. And one of the things that I will say to parents when I'm introducing the concept of medication is there may be a side effect, and one of the somewhat reliable side effects of fluoxetine or sertraline in young children is disinhibition. They might get a little disinhibited. We actually want that side effect because if they get disinhibited and then they talk a little bit more because they're disinhibited, well, talking becomes pretty quickly inherently reinforcing. So it's okay if we get that side effect if it is not too intolerable for the child. All right. Another question is, how do you provide CBT for fear of school gun violence, avoidance of school due to fear of violence? Let's think about exposure-based CBT. Much of what we treat when we use exposure is we expose to things that are safe enough. So I treat lots of choking phobia, in which what is the exposure to? It is not to choking, it's to good, fast swallows of food. And we start with the easy stuff like yogurts and puddings, and then we race up the hierarchy to string cheese and steak. Those are always at the tippy top. Could a child choke? Yes. Is choking dangerous? Yes, but it is highly, highly unlikely. Same with exposure to dogs or to spiders. Could a household spider be poisonous? And if you're kind of hanging out with it, could it leap at you and bite you and turn out to be poisonous? Almost certainly not. Same thing with most dogs that we pet. So we make a decision that these exposures are safe enough for children. And what isn't safe enough for them is avoiding things that other kids get to do without thinking twice about it. So while school violence is a reasonable thing to be worried about for children, avoidance is not a good thing for them because the actual relative risk of violence at school is low. We're talking about school shootings. So hence, I would treat that like any other exposure, and that is, what does a child who's avoiding school for any reason need exposure to? And it is going to school. The question is a little bit different if the child has actually experienced violence at school and now is suffering from PTSD. In that case, I would treat the PTSD first via prolonged exposure, helping the child remember and develop a narrative. And then I would also start attacking the unnecessary avoidance. Once we have the narrative down, they've gotten some symptom relief, and then we're going to be going back and gradually reintroduced going to school. Another wonderful question. Any other therapy tips or tricks you can give us for treating anxiety/depression that we can complete quickly during the med check? Yes, I think I can answer that. And that is, I tell my students, my interns, my externs, my fellows this. And it is when you have a child or a teen, it's usually a teen, who's presenting both with an anxiety disorder and depression, treat the anxiety disorder first, and you will probably get relief from the depression for free. What I mean by that is developmentally, anxiety disorders show up first. So it is usually the case that the anxiety disorder showed up first in the child or teen's life, and then the avoidance that is maintaining that anxiety disorder, the avoidance of school, the avoidance of going out with friends, the avoidance of doing things that are scary but safe enough, leads to a level of withdrawal that then probably fuels depression. So you want to treat the anxiety first, get them out, get them doing those scary things until they're not scary anymore. And then suddenly their lives are a lot better, and they're engaging in true behavioral activation, which is an evidence-based psychotherapy for depression in and of itself. So that's what I recommend. And I do tell my patients that as well. It looks like you have both an anxiety disorder and depression. We're going to go gangbusters after that anxiety, and then anything that's left over with that depression, we'll clean that up with a little extra CBT. And we never really have to because they get a lot better. The one exception to this is I clean up the anxiety disorder, but the child, the teenager, is still going to bed too late and having to wake up too early in the morning. So they're chronically tired. I cannot tell you how many children have walked into my office saying, I have social anxiety disorder, I have GAD, I have depression, and I ask them about their sleep, and I find out that they are chronically underslept. We get their sleep re-regulated, and then suddenly I don't have much work to do as a CBT therapist other than doing that CBT for insomnia. What do you do when it is extremely difficult to decide whether a teen's anxiety is a true anxiety versus intentional to avoid chores, school, etc.? Well, my students, my interns, my externs, my parents asked me this question all the time. You say that anxiety disorders are maintained via avoidance, Dr. Dahlsgaard, but sometimes I think my teenager is avoiding doing chores, is avoiding going to school because he just kind of doesn't want to, but he's figured out if he says, I can't do it because I'm anxious, it gets him out of doing it. Do we need to tell, is the treatment any different? The answer is actually no. So the treatment for both, whether it is avoidance due to anxiety or avoidance due to, I just don't feel like it. We have a teenager who is kind of suffering from the same thing functionally, and that is they are not meeting developmentally appropriate expectations for getting out there and doing stuff they would rather not do. So they are either attempting to avoid anxiety or they're attempting to avoid frustration, irritation, or the I just don't want-us. So what do? Same thing. We treat it like an exposure, and the exposure is to a distressing emotion. Can you tolerate that distressing emotion? And because it is a good thing to use rewards for any kind of exposure, right? Rewards are feedback. The child does the brave thing, whether that's tolerating anxiety and moving forward or tolerating frustration, boredom, the I don't want-us, and getting the job done, we still reward them. Another question from the audience. How can you sell the need to do 6 months of CBT when people want to take the time-efficient option of taking a pill for anxiety? I have 2 answers to that. The first is that for the anxiety disorders, for most of them, for both the pediatric population and for adults, medication alone, the SSRIs alone, are a bona fide, well-established treatment. So I do not blame anyone who is educated about CBT as an evidence-based treatment for anxiety disorders, and for most anxiety disorders, SSRIs are evidence-based as well. I don't blame anyone for saying, you know what, I would prefer to take a pill. I would prefer to take an SSRI. It can be hard to go to therapy. It can be expensive, not just in terms of money, but in terms of time. And it can be hard to find a good exposure-based CBT therapist. So I do not consider it a tragedy. And I am a CBT therapist. I do not consider it a tragedy when a patient chooses an SSRI over me, because both treatments are evidence-based. Now, with regard to a case where you think, you know what, this kid, this adult, should really try a round of CBT first before an SSRI for whatever reason. One of the ways to sell it is to say, hey, in the trials, both for the anxiety disorders and for OCD, the typical length of the randomized controlled trials, the best delivery of CBT that we have on record, good adherence and fidelity to the treatment manuals, those manuals are 12 to 16 sessions. So if you think weekly sessions, 12 to 16 sessions is 3 to 4 months. It's not 6 months. The other is that many CBT therapists will do an intensive. And an intensive is, I'll see you twice a week and we'll get going. And then that can cut down on the length of therapy. There's also a wonderful emerging literature. It just keeps getting stronger and stronger on doing single session exposure treatments for certain anxiety disorders, and they work quite well. So I think that's a reasonable and quite evidence-based way of letting patients know it probably isn't going to be 6 months. So I see patients for 2 months, maybe 3 months, and then we switch to boosters just to make sure that there's a maintenance of gains. And so the boosters might be once a month for 2 or 3 months. So maybe I'm going to be in their life for 6 months, but it is not going to be weekly therapy for 6 months the vast majority of the time. Anxiety disorders respond beautifully to exposure-based CBT. All right, that's all the time we have today. I hope my answers will prove useful to your practice, and best of luck to you with your patients.
Hello, everybody. This is Dr. Roger McIntyre. Good to be with you. We've just wrapped up our session, both myself, my good friend, Dr. Vlad Maletic, here at NEI in what has been a very snowy Colorado Springs in Colorado. We had a session today, and what we focused on was, I think, one of the hottest, most interesting, and most hopeful areas in psychiatry today, that being the role that inflammation might play in the cause of mental illness. Broadly, we focus mostly on depression as an exemplar, and really, in fact, using this platform to not only really inform our models of disease pathogenesis, in other words, from a conceptual perspective, which is always interesting, but in addition to that conceptual offering, the offering of inflammation and its potential role in causing mental illness. What does that mean for us as clinicians in day-to-day practice? And what does that mean for the future therapeutics? What does it mean for how we think about the mechanism of action of our current therapeutics today? Are they anti-inflammatory? And this is a topic that I don't think anymore is in the hallways of academia or the hallways of universities and so on and so forth. This is something people are talking about on TikTok and social media. There's a lot of interest in the public square, so to speak, of the topic of inflammation. So it was a lot of fun to do this presentation with my good friend Vlad Maletic, who also is an academic with tremendous wealth of knowledge and information in this area. As is always the case, we received many questions here at NEI for all of our sessions, and I think the inflammatory one really generated a lot of questions. We didn't have enough time to get to all the questions, so I'm going to take this opportunity now to address additional questions we weren't able to cover either entirely or at all during the live open session. Let's get started if we can. Okay, so one of the questions coming in is the food as medicine movement diet? It consists of whole foods and mostly plants. Can a healthy diet such as this reverse and prevent inflammation without really anti-inflammatory medications? Look, this was a question from one of our colleagues. Thank you for the question. It's a fantastic question. And I think that the point I think that emanates and surrounds the question is really, really fascinating. And that is, let's start off with diet. Does diet evoke the immune inflammatory system? Secondly, does the diet have any impact on propensity to mental illness or protection from mental illness? And I guess thirdly, should modification of diet be considered as a way to treat mental illness? And fourthly, if it does treat mental illness, what's the mechanism? Is it anti-inflammatory? So there's a whole bunch of mechanisms here. So the first question around diet is so interesting. I don't think anyone has been left out on this one. I think most people know that diet clearly can affect health and disease status. More specifically, we do know that some types of diet, and more specifically the composition of that diet, could affect the body's immune inflammatory system. Let me be maybe just very brief on this. For example, we know diets that are high in sugar are absolutely associated with increase in inflammatory responses. That's well documented. We also know diets that are enriched in caloric intake, high calorie diets, can also, regardless of the composition, evoke the immune inflammatory system. Now, study after study has shown that when investigators look at the relationship between diet and diet composition, there does seem to be a relationship to the risk of mental illness. Now, mental illness is a very big category, but there are only some mental illnesses that have been really largely focused on, like mood and psychotic disorders. Let me give you an example. Studies have shown at the population level, when people are using what's called a Mediterranean diet, these are diets that do not have, as we often have in North America, a lot of refined and processed foods, but instead of other foods a lot of fish, a lot of olive oil type foods, and so on, the rates of depression in these countries that are known for their, in quotes, Mediterranean diet seems to be lower than countries that don't have such Mediterranean diets. Related but different, diets that are high in fish consumption at the population level have also been associated with a lower population level of depression. Now, someone might say, well, that's kind of interesting, but that's kind of an association, isn't it? I mean, do you really know that's cause and effect? And I would say that's a very, very good point, and that's still under investigation. But when we look a little further, what we also find is that in many, many people who are living with mental illness, they do have diets that tend to be very high empty calorie diets. They have, and part of this is economics, of course, and they often tend to have diet behavior like binge eating and overeating, which, of course, as I mentioned earlier, is also linked to inflammation. So I think what I would say is that there is, in fact, reasons to believe that a balanced, healthy diet is probably the best place to start. I think as it relates to whether a specific type of diet is necessarily protective or a diet that's therapeutic in someone who has a mental illness is to be determined. Investigators around the world are looking at diets like ketogenic diets or fasting diets or diets that are at certain times of the day trying to keep your food consumption before lunch hour, or fortifying the diets with certain foodstuffs like fish oil and things of that nature. These are all hypotheses to be tested. I don't think we can say that there's any one of these types of diets I've just mentioned that's fit for purpose, but they certainly are fit for research, and we need to find out what this study's results tell us. But I think in the interim, I would summarize then by saying that there's no question that diet does affect the inflammatory milieu. Second, some diets are more inflammatory than others. And thirdly, there are in fact data to show that in the diet, perhaps through the inflammatory metabolic system, may be increasing or decreasing risk of mental illness. And for now, what I would say is we don't have any recommendations around any kind of specific diet, but if we can get patients from their current diets up to a healthy diet, along with exercise, sleep, social connectedness, that seems to me to be a very fit-for-purpose strategy. Our next question coming in is, do you recommend drawing inflammatory markers in patients? If so, which ones? Do you have an algorithm you use to determine which inflammatory markers that we should be taking or not? Love the question. So if inflammation is alleged to be relevant to the pathophysiology of depression, maybe it's also relevant to the response likelihood of an SSRI. In other words, we have some data to show that if patients have increased inflammatory markers, the probability of responding and remitting to an SSRI attenuates. So if that's the case, I love the question. Why don't we just check their inflammatory markers? If they're elevated, then maybe I shouldn't put my patient on an SSRI. Very good thought. At this point, I'm going to answer to the question by saying no. I would say we're not yet ready to recommend routinely measuring someone's inflammatory markers like a CRP or IL-1, IL-6, different cytokines, chemokines, and so on and so forth. Some might be saying, why? Why am I not emphasizing that? The literature seems pretty compelling. Well, in order for us to recommend that we should be routinely measuring these markers, there's some additional research that needs to be in place. The first checkbox is we have established that there's an increase in inflammatory markers. We've also established that in some cases, these elevated markers could attenuate SSRI response. But there's more checkboxes we haven't filled in yet. In other words, one checkbox would be, if I do routinely do this, does it have any impact in a reliable, reproducible, meaningful way for most people? And then the next checkbox, is this a cost-effective strategy? And those checkboxes and a few others have not actually been completed yet. So for now, this is certainly very curious. It's a curious topic. It is certainly a highly replicated finding, but I think we still have, as I say, to round the horn a little bit. In other words, there's a few more checkboxes we need to check off before I could stand up and say, guess what? The science is strong. It's also been shown to be rubber tested in real world practice that it makes a difference to the health outcome. and it is cost effective. So it's a bit of kind of additional points that we still need to think about. But again, I don't think we're saying throw the baby out with the bathwater. We need to do those additional studies to show utility and clinical usefulness as well as cost effectiveness. Okay, here's a question. What are my thoughts about this whole self-harm? Oh, what, so wonderful. The thoughts on self-harm, causing inflammation, and then that leading to depression. This is such an interesting question. We do know that many of our patients do engage in self-injurious behavior and self-mutilative behavior, and this is not confined to any specific mental disorder. It cuts across many different conditions. And I don't think we are really at a stage where we fully understand that behavior. But I do think in some situations, there is in fact a biological effect that is either being reinforced with this type of behavior. Now, historically, people talked about opioidergic dysregulation as playing some part in self-injurious behavior. There was a lot of work with serotonergic mechanisms. Maybe this reflects impulse discontrol in these patients. But I do think this is an interesting thought that maybe in some people, this type of self-injurious behavior may provoke inflammatory systems, and the provocation of the inflammatory system in the long run is clearly doing harm. I think that could lead to further compounding or amplification of psychopathology. But it would be an interesting and testable hypothesis that the at least near-term effects of provoking the immune system is a temporary reduction in anxiety and arousal. Now, when you provoke the immune system, you tend to, on the whole, increase anxiety, threat, and increase in anhedonia. But that's not in everybody. Some people, when they have their immune system provoked, they don't have an increase in anxiety. In fact, the opposite. They feel, in fact, more apathetic. They feel more fatigued. They feel more withdrawn. And for someone who has chronic arousal, that might be, in the near term, a little reinforcing because it offers some escapism from that terrible disquiet of hyperarousal. So it's an interesting hypothesis, an interesting question indeed. But to be clear, in the long term, the chronic activation of the inflammatory system, which I would posit is occurring in someone who has repeat self-injury, would, again, in the long term, would be very harmful and probably propagate their illnesses. Okay, next question is, does the glial hypothesis and anti-inflammation help explain depression in multiple sclerosis? Absolutely, that is the case. So multiple sclerosis is a condition that is immune-based, that's well known. Multiple sclerosis is differentially affected by many mental disorders. Not only is depression elevated in MS, but so is bipolar disorder. In fact, 10% of people almost who have MS also meet the criteria for bipolar disorder. If I could broaden the question, I might even broaden it elsewhere. What about ulcerative colitis, irritable bowel syndrome? What about migraine? What about cardiovascular disease? What about arthritis? In other words, if we were to look at other chronic disease states that are characterized by alterations in the immune inflammatory system, I enumerated many, I didn't list them all, they're all affected at a higher rate of depression when compared to the general population. And yes, in the case of MS, it is the current and prevailing view that the overrepresentation of depression, bipolar, and other types of mental disorders in this population and other populations characterized by inflammatory disturbances is in part due to the alterations in the immune inflammatory system. So absolutely that is the case. Then it introduces an interesting hypothesis, and that is if we can treat the MS more effectively, can that actually protect and treat some of the aspects of mental illness? Said differently, if we treat and prevent mental illness in people with MS, can that have a halo effect, if you will, on MS? Can it help the other condition? And those are interesting hypotheses, and there's some lines of work to show that that is the case. For example, we know when we treat depression well, it has benefits on other conditions like cancer or cardiovascular disease, just to name a couple. Next one, does cognitive impairment associate with obesity resolve upon returning to a normal weight? Yes, it does seem to be the case. Now, not always, but in most cases. And here's a part that's really, really interesting. For example, when you look at individuals who have very high BMI, who are eligible for bariatric surgery, when they go for bariatric surgery, studies have been conducted, many studies in fact, evaluating as part of their intake their cognitive performances. And what investigators have done is they have compared the cognitive performance objectively measured prior to bariatric surgery to the objectively measured cognitive functions after bariatric surgery. And what's interesting is that on the whole, we see an improvement in overall cognitive functions, and we see an improvement across many of the subdomains of cognitive functions, executive functions, memory, learning, processing speed, and attention. So it is absolutely the case that improving weight, reducing BMI, reducing excess adiposity does bode well for improving cognitive functions. And it's interesting because it cuts both ways. In other words, if you have higher BMI, it adversely affects cognition. If you improve the BMI, it improves cognition. Said differently, if you have abnormalities in cognitive control, which is exemplified in people who have ADHD, that could increase the risk of obesity. So cognitive dysfunction could predispose, portend obesity, and obesity could predispose, portend cognition. That's why I often say here at NEI that obesity metastasizes to the brain. Next question. How does cannabis, alcohol, and other drugs affect inflammation? Well, I would like to come up with a one-size-fits-all explanation. It's tough. I'm going to do my best. The short answer is it is evoking anti-inflammatory effects. At least alcohol and drugs like cocaine, drugs like crack, drugs like heroin, they have this effect. Cannabis is more complicated because cannabis has over 100 cannabinoids in it, depends on the cannabis type, potency, and so on and so forth. But a case has been made that some cannabinoids, such as CBD, may actually have some anti-inflammatory effects. So I think there's a different conversation. Cannabis is always a tougher one because we don't even know what's even in the plant. Often people are smoking it, and it really is composed of many, many, many different types of chemicals in over 100 cannabinoids. But CBD specifically may have, in some circumstances, anti-inflammatory properties. When we look at combination versus augmentation strategy, should we think about adding bupropion if overweight or atypical symptoms are presenting in patients? I think the question is so important because we got to prevent obesity. Our drugs often are offending agents with respect to causing weight increase. And I believe without any hesitation that the drugs that have less weight gain liability have to be prioritized. And so the short answer is yes. I would consider therapeutics in a patient who has SSRI or SNRI or vortioxetine inadequate response. My augmentation strategy would not be bupropion first. I tend to go with atypicals, either on-label atypicals that have low liability to weight gain that are approved in this area. I'm thinking about agents like, for example, cariprazine, which is approved, or brexpiprazole. We look forward to hopefully new indications in the future. Some new data now for lumateperone showing efficacy as an adjunct in MDD. We know that drug is a weight-neutral drug, so we'll look forward to FDA's decision next year on that agent, but it's certainly fit for purpose in my view with respect to giving it to patients. But if patients don't benefit from an atypical, a second-line approach might be in some cases a bupropion. Finally, if patients do have major depression or bipolar, and they are overweight, obese, whether the medications were the offending agents or not, I do think that the weight does have to be prioritized to the same extent as their psychopathological symptoms like depression, anxiety, and so forth, because we know that the overweight obesity is going to influence the probability of response. And that's why I think diet, exercise, sleep, but also in some cases, the use of medications. GLP-1 receptor agonists we talked about here at NEI as antidotes to psychotropic drug weight gain. But again, they're already indicated for use in treating obesity and related conditions, diabetes, type 2, and also the prevention of cardiovascular mortality. in people who have obesity. So I want to maybe wrap up today's session by saying the following. We certainly have an interesting paradigm, the one that has posited the role causative of inflammation in mental illness. And this paradigm is providing fertile ground for us to hypothesize that perhaps in some people, the prevention and treatment of mental illness may be through the pathway of modulating the inflammatory system. A call out to all of you, and thank you for your questions. I really appreciate it. And again, a thank you to my good friend Vladimir Maletic, who worked with me on this particular session. So stay well, and we look forward to continuing the conversation in the future.
Hello, my name is Dr. Thomas Schwartz, and I'll be answering some of your questions about my presentation called Wake Me Up Before You Go-Go, Strategies for Improving Sleep-Wake Issues. So let's get started. So during my talk today, we brought up several topics, but we had to go very quickly through them, and I asked you to pose some questions, and we'll go through them right now. So one of the first questions that I didn't get a chance to answer today goes like this. Dr. Schwartz, I would love to hear your theory and use of caffeine as a treatment for hypersomnolence. So use of caffeine is interesting. I am certainly not advocating taking caffeine tablets, drinking 2 or 3 Red Bulls or full throttles, but I can tell you a little bit about what I know about caffeine and its clinical use. Remember, it's an addictive substance, so if somebody has never really drank coffee as a treatment, let's say, maybe you don't want to introduce them to it. But where I find caffeine to be effective is when somebody's maybe a 1 cup a day, 2 cup a day, let's say coffee drinker, for example. So they're already on it. They know what it's like. They're already addicted. And you could fine tune the way they use their caffeinated beverage. So with this, a lot of people think you need a big, huge cup of coffee, right? And you need several of those throughout the day. It's really not true. When you look at the studies on caffeine, you probably need a regular-sized cup of coffee, maybe 12 ounces, not 16 ounces, not 32. And you drink that when you get up. And, caffeine has a half-life, and it starts leaving your system, so the stimulant effect is going to wear off. So maybe you drink a cup of coffee in the morning. Then maybe you have a second cup of coffee an hour or two later. And then you have a half a cup of coffee an hour or two later, and then a quarter of a cup. You really don't need a lot. And so that's one of the biggest misconceptions. If somebody's already drinking 6, 7, 8 cups of coffee a day, this strategy won't work. Their system is saturated. They've built up a tolerance, for example. But what I like to do, if somebody drinks a big, let's say 32-ounce cup of coffee in the morning, have them drink a 12-ouncer. Wait a little bit, then another 12-ouncer, then another. And you make it TID. And you make it a slow-release drug instead of one big bolus dose in the morning. And again, the other strategy is, drink a full cup of coffee, then 3/4 cup, then half a cup. You're kind of doing your own taper as the day goes on. And what caffeine tends to do is it tricks your brain. It blocks adenosine receptors, also allows more dopamine to be more free-floating. So you get dopamine alerting. That's the part that can be addicting. And you trick your brain into thinking it hasn't been awake as long. So caffeine sometimes is a simple strategy, and that's how I use it. For the next question, the audience members asked me to comment on the use of mirtazapine, the antidepressant, as an off-label treatment for insomnia. I think in clinical practice, it's a fantastic choice, especially if the patient has a depressive disorder with anxious distress and especially insomnia. A side effect of this medicine is making people feel fatigued, insomnolent, or sleepy. You can use that to your advantage. You dose this at night, maybe a half hour to an hour before bed. It reaches its peak plasma levels, and people get tired and go to sleep. Oftentimes, you don't need a secondary sleeping pill. You don't need to use a Z drug or a DORA drug because it has its own built-in sleeping medicine. How does it work mechanistically? It has antihistamine. So when you block H1, you're removing arousal, right? So histamine's an arousing chemical. We're going to block its effect. I think that's part of it. And that's what probably gets you to initiate sleep and maybe stay asleep. Mirtazapine also blocks serotonin 2A receptors. And I don't think those are sedating, but they tend to promote deeper sleep. So you kind of have a sedative that gets you to sleep, and then the serotonin 2A antagonism probably keeps you in a deeper, more efficient sleep. So it's kind of a nice 1-2 punch. So I do think it's effective as a standalone antidepressant with a built-in sleep-producing apparatus. Can you use it as an add-on, like to an SSRI, SNRI? Absolutely you can. I think Linda Carpenter's work out of Brown shows us this is one of the most effective combination strategies for treating depression. And if the SSRI, SNRI didn't work for your insomnia or anxious distress, or it actually created some as a side effect, I think the mirtazapine combination does a good job of canceling out those side effects. So like Dr. Stahl says, it's great to get into win-win situations where you're boosting effectiveness of a drug to be a better antidepressant, and you're canceling out each other's side effects. And I view mirtazapine as a really nice combination strategy. Another question asks about melatonin and what are my recommendations using it as a sleeping medication. So melatonin is over the counter, and I'm not sure it's the greatest sleeping pill. It doesn't seem to have a knock you out pro-somnolence effect. Its best data is actually helping jet lag and circadian rhythm shift type disorders. But as a sleeping pill, I think it is fascinating. If your patient can actually get themselves drowsy and into light sleep, that's where I think melatonin does its magic and takes over. So when you take melatonin, it agonizes the MT1 and MT2 melatonin receptor system. And I think the first one dampens your reticular activating system. So we dial down norepinephrine and dopamine, for example. We remove arousal. And then the MT2 agonism keeps your 24-hour clock, maybe your suprachiasmatic nucleus, entrained to 24 hours. So mechanistically, melatonin's really cool. But it's kind of light. Its bioavailability is poor. All of it doesn't get across the blood-brain barrier. The preparations over the counter are variable in how much melatonin's in them. So sometimes it works, sometimes it doesn't. But if the person is bolt upright, hyper-aroused, jittery, I'm not sure it's big enough to knock somebody out. But if they can drift into early sleep, it takes over and does a very good job. Not addictive, not much hangover. It's probably one of the safer insomnia treatments we have. So I like to start with it in a fair amount of people for that reason. And a lot of patients have tried it because it's over the counter. Dosing was asked about 3 milligrams. I try that for 2 weeks. If melatonin's funny, sometimes it doesn't work on the first night or two. You need to suggest to people that I need you to take it for 2 weeks. Do some sleep hygiene activities to improve your sleep schedule and those things. But give it 2 weeks. If it fails, I have them go up to 6 milligrams for another 2 weeks. Then I go to 9 or 10. So they come in 3 or 5 milligram dosing strengths, usually over the counter. So maybe it's a 6-week trial at low, middle, and high dose. And if it doesn't work after that, I do take people off of it. It's just like any drug, it didn't work and it failed, and we're not going to let you hang out on it forever. And like any primary insomnia, if you get people back to a good sleep regimen over several weeks, then I think you can kind of taper it off slowly and get rid of it. Some people need it chronically. We have people that just are never going to sleep well again without a treatment. So I've had people on over-the-counter melatonin for years. The final trick is the slow-release melatonins seem to work better. And so maybe you're not going to use the 3, 6, 9, or 10 milligram strategy, but slow release keeps more of the drug in the system, gets more across the blood-brain barrier. So sometimes that's a gimmick if the immediate releases fail. And then the final thing, is empty stomach 1 to 2 hours before bed. It'll absorb and improve your outcomes, I think. I have another question asked about increased alertness if you use GABAergic drugs, so like benzodiazepines, for example. So we typically say that if you increase GABA A receptor positive allosteric modulation, you make it more efficient, you turn it on more. The side effect is sedation, psychomotor impairment. That is the norm. But the writer of this question is correct. Every now and then, you'll see some people get hyperactive, hyper-alert. They get paradoxical effects. You see that more in geriatric patients and sometimes in kids. In my 20-plus career, I've maybe seen this once or twice. So I think it's a rarer phenomenon, but it does happen. And then you may not be using the benzodiazepine type drugs when that happens. You'll see this with the antihistamine products too, like diphenhydramine, over the counter and some of the prescriptions we issue. So some of the sedating antidepressants, the penes like olanzapine, quetiapine, antipsychotics. Sometimes people get kind of hyperactive on these things and maybe tolerance or tachyphylaxis build. They sleep great for a couple days and then they don't. Everybody's brain is different. And I suspect in some people using GABA-based drugs or antihistamine-based drugs, their system may already be saturated. They may have genes that make their receptors desensitize and downregulate more quickly. So then the drugs are ineffective and backfire. So that does happen. That's a great observation from the person who wrote this question. And then, you really can't use these drugs. You're going to have to try something else mechanistically. Another question here asks about patients going through rebound insomnia. That's a great question. So if we have somebody on a true benzodiazepine for sleep or a BZRA-Z drug for sleep, these are drugs that really amplify GABA-A receptor activity. And we know that then you can see desensitization of the receptors, downregulation. So the same milligram dose doesn't create good enough sleep. Then you got to raise the dose and then do it again and again. So this is tolerance, just like we'll see in alcohol use disorder. So it's a law of diminishing return. So once you've done this a few times, you realize you're on that pathway, you probably have to take somebody off. If you take somebody off too quickly, what you've done is you've raised the brain's GABA activity level, so your brain parallels that with glutamate. They always want to be balanced. When you yank the GABA away, all you get is glutamate excitation around. People are sweaty, shaky, might be in a little bit of withdrawal. But the psychological withdrawal is called rebound anxiety or insomnia, and they're hyper alert, can't go to sleep. And it's a really crummy situation. So you just have to do a really slow taper. So when I bring people off benzodiazepines, I tell them this is a 3 to 6 month thing that I'd like to do. It's not 3 to 6 weeks. Some authors write that you can take a quarter of the dose away every few days. That's really fast, and people get scared. Because these drugs work, you take them and they work right away. So in their mind, I took it, it worked right away. If it gets out of my system, it's going to fail right away. And then you get the real rebound anxiety, which is a mild level of withdrawal. So just take your time, quarter tablets in half. Take tablets, don't just half them, but quarter of them. And, if you have to, and go really slow. Patients relax a little bit more. They don't get nocebo withdrawal effects, and I think you can navigate that. Sometimes I'll try a detox protocol, certainly switch them to a longer-acting benzodiazepine that kind of self-tapers. You'll have less withdrawals. But you can use other medications, gabapentin, pregabalin. They're not GABAergic drugs, but they do help sleep. They do help calm people down, and patients feel like we're at least doing something. And I think, again, you get less panicky, nocebo expectancy side effects. So sometimes we'll kind of do a pseudo detox protocol as well, but it's tough. Just take your time and go really slow. Another question talks about supplements that might be good for healthy sleep. Again, I think melatonin is the one we spoke of earlier. I think that's a good place to start. Some people will take low-dose magnesium. Some people will take valerian. The data to me there is not as compelling. And I don't want to come across saying that everything is placebo. Clearly, melatonin has beat placebo in certain studies. But almost any sleeping pill I give to somebody has a 40% placebo rate. So oftentimes people will try over-the-counter things that don't have any, quote, outcome measures or evidence-based, but they're doing great. I never ruin placebo effect. I never tell them to stop whatever they're doing, unless they're getting some other side effect. But you can certainly try any of those things. But melatonin is probably the best one in my practice to consider. The final question I have here is asking about specific sleep issues with perimenopause or menopausal patients. All the same rules apply. Insomnia is insomnia. You can use over-the-counter melatonin. You can use over-the-counter antihistamine products like doxylamine, succinate, or diphenhydramine. I think prescription non-addictive medicine should come next. You have the melatonergic agonist, Ramelteon, the antihistamine low-dose doxepin, and then you get into the DORAs probably, right? The dual orexin antagonists. And if they don't work, you get into the Z drugs, the BZRAs, and then you get to the true benzos. I use this systematic approach for every patient because you're starting with the safest things first and then going to the riskier things at the end, kind of the bigger guns at the end. And then specifically for perimenopause or menopause, I think it's insomnia, and the treatment should be the same. Don't forget about cognitive behavioral therapy, sleep hygiene protocols. They can be effective. What I will say is if patients have vasomotor symptoms, hot flashes, and they clearly identify this is what is keeping them awake, they have to get up to change their bedclothes or bed sheets a couple times at night, then I do think you want to treat the vasomotor systems. If they're a candidate for estrogen replacement therapy, it's a great place to start. And other medications, some of the SNRIs and even SSRIs have some ability to help hot flashes. Again, remember the SSRIs and SNRIs sometimes ruin sleep and create insomnia as a side effect. So you'd have to be careful there. But if you see vasomotor symptoms, treat them. If the insomnia continues, just start an insomnia protocol and going with the safest things first. And I think you'd be in the right place by doing that. All right. So those are some of the questions we couldn't get to today. That's all the time I have here now. I hope my answers will prove useful to your practice, and best of luck with your patients. Thanks a lot.
Hello, I'm Lisa.tremayne, and I'll be answering your questions about my presentation, which was called Beyond the Blues, Risk Recognition and Relief from Perinatal Mood and Anxiety Disorders. So let's get started. First question is talking about the risk factor of experiencing trauma and wanting to know, does that hold true for trauma related to current events? Well, how timely is that question? Or is it just more personal? My organic answer to that would be that, yeah, it definitely could be from current events, because what you perceive as trauma, what you perceive or feel is a threat or you are worried about is real. And that's where we start. So I would say yes. And we certainly did have a number of patients the day after election, hypothetically, who we had to hold some really fragile space for. So that was a great question. Has anyone looked at rates of depression and anxiety in same-sex couples and who adopt newborns or other adoptive parents? Yes, we will. At our center, we have same-sex couples. We have surrogate moms, and we have post-adoptive PMATs. So that comes up a lot with us, and it really is no different. And I'm sure that didn't shock you. As far as there are studies, I have trouble even finding current studies, within the last 5 years to produce data on even a broad stroke under perinatal mood and anxiety disorders. So I would say if you find one, can you email it to me? What is our approach to discontinuing medication, if applicable, when symptoms improve? 100% on board. We always say to our moms that the medication it's a triage of care. We bring you in, we wrap you in support, we start services for therapy, whether it's individual or group, and then we talk about medication and how it can help you during this time to really be ready to be helped the other ways: therapy, peer support, education. We keep everybody on the dose that is therapeutic for them for 6 months, and then we reevaluate. And our program goes till the babies are 12 months. So we're right in there. A lot of people wind up staying on if they're going on an SSRI because they have found that it makes their life better. It makes it easier. OTMS. It is considered just like ECT, but again, there are no specific studies showing the benefit or ongoing benefit of TMS. So I would truthfully not want to answer that and be false, but would love for you to send me information if you have it, because I add that into everything I do. Next one is PMAD decline medication for months before they will agree to take it. Oh, yes, you are my people. And all I can think of is, yes, we have so many women. And again, what I talked about with the type A personality and the perfectionist, you can imagine the careers that go along with them. And in fact, there was just a study that I don't know off the top of my head that showed the increase in PMADs in the healthcare provider field and how many more people are affected. So, you know, the old, if I know too much. So if I know about medication and I know, you know, what could be wrong or what could be a side effect, I'm so hyper aware that it's really hard for me to take it. And then you add in that their family members, their partner, their culture, their other doctor might be talking badly or saying it's not needed or it's not okay to use. We're up against a lot. The brochure that we have at our center, I'm more than happy to share. It was written by a pharmacist. It was then edited by our psych NPs, and we have found that that really helps, something in hand. Thank you for presenting. Thank you for coming. Do I have any information on partners or spouses with mood changes? Yes, absolutely. The latest study shows that 1 in 10 partners can be hit, 1 in 10 can be feelings of anxiety or depression. I often say adjustment and overwhelm. They're highly underrated because it's a transition. You're going from 2 people to 3 people or 4 people, and that they should not be left out in the cold. Often our second session in the office, whether it's with me and the mom and the partner, or with the therapist and the mom and the partner, sort of as a psychoeducation moment, answering questions, just giving them information, is we find that clears a lot up. We've used Abilify with women during pregnancy that experience lactation failure. Is there any data or side effect in pregnant women? We absolutely use Abilify. That's like one of our top 5. I have not had any feedback on breast milk decrease, but I work with a lactation consultant who I can actually ask if she has any. So if you'd like real information, email me with this question again, and I will answer you personally to make sure I'm giving you the right information. I've read that you should stop using SSRIs in the first trimester. Others say stop in the third. Others say take it throughout. What are your thoughts? That's pretty much the problem, right? So we're always dealing with where the mom is at. So if she's coming to us pregnant, 12 weeks, so anxious, can't sleep, can't eat, ruminating thoughts, we definitely want to get an evaluation for medication and how that could help relieve those symptoms for her during this pregnancy, making the pregnancy have a better outcome. But you are up against someone who's really believing that the medicine isn't something they should be taking. Because this information is out there. Don't take it in the first trimester. Don't take it in the third. And everyone can find what they want to find on Google. So we use the risk scenario. What if you don't? And what is this doing to your fetus in the first trimester? If you don't take it in the second trimester, how is that feeling going to be? In the third, when you're preparing to deliver. So we do make a lot of headway that way. One of our, my psych NPs will, with women who are really concerned, wait till organ formation after the first trimester, and that seems to do enough for the mom's level of anxiety and what she has read. So we will do that. What is the acceptance level of male practitioners helping in this space? Well, had you asked me a year ago, I would have said I hadn't met one. But I collaborate under the director of OB, and I have a dotted line to psych. In the past year, I have had an OB fellowship who is a man. I have had a psychiatric pharmacist who's a man. And I now take nursing students from 2 of the schools, and I had nursing students come in who are men, and it's nothing. It's great. It's working. We overthought it. Definitely, it's okay. We work in a team program. with at-risk teen moms. I deal with a lot of anger and rage and aggression. Yes, I've used a lot of bupropion and albuterol. You know how good I am at this, and treat substance abuse with naltrexone. Any suggestions to ease this? No, and bless you. You're doing amazing work. That's exactly what we used to. Literally the combo. A lot of work we do with our young moms is rage, is anger, is more of a physical agitation, and that's exactly the substances we use too. So, bless you. You're doing God's work. Please don't stop. We need you out there. Do you recommend following mothers past the first year? So much so, yes. In fact, we're looking into opening up a maternal wellness center now so that when my moms graduate from our program and have realized like the amazing work they've done in the time they've been there on issues they had that they never wanted to deal with, or issues they had they didn't even know they were dealing with, or just really becoming the best person they can come, they don't want to stop. And, there's not enough therapeutic help out there for all of these people. And so I have to graduate the moms and refer them out to people I know. That's me. So I will only hand them off to someone I know. It's a great list. We really do. But it would be a nice continuum of care to have a maternal wellness center where then we could have moms continue the work they've been doing and also have psychiatric nurse practitioners available if they are choosing to stay on medication to have it managed by the right person. So 100%. We had to put a parameter on the program because of our volume. So we chose pregnancy through the first year. I hope that answered all your questions. That's all we have time for today. I hope my answers will prove useful to your practice in some way. Best of luck with your patients, and please don't be afraid to use my email if you have further questions or want clarification, or I can be of help in any way. I truly mean that. Thank you.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.